let's talk about metabolic acidosis. So to understand metabolic acidosis, let's understand the concept of anion gap. So normally, let's suppose this is your blood, and inside the blood, the total cations is equal to total anions inside the blood. So what are the major cations inside the blood? Sodium, potassium, magnesium, copper, zinc, and many others. And what are the anions? Chloride, bicarbonate, sulfate, phosphate, albumin, and a variety of other anions are present inside the normal body. And the total amount of cations is equal to total amounts of anions to maintain the electroneutrality, unless there is pathological condition. So in pathological condition, what happens that, let's suppose a patient has diabetic ketoacidosis or starvation ketoacidosis or alcoholic ketoacidosis, whatever. So if ketones are added, so total amount of anions increases. Or let's suppose with lactic acidosis, so lactate are added, or ethylene glycol poisoning, glycolate anions are added, or let's suppose there is salicylate toxicity, so salicylate anions are added. So in pathological conditions, when extra anions are added, then that causes high anion gap metabolic acidosis. Why high anion gap? Because these anions increases the normal anion gap. So you know what is the sodium concentration in our blood? 135 to 145 MEq per liter. And what is the potassium concentration? 3.5 to 4.5 MEq per liter. And these are in minor amount like 0.6, 0.7 magnesium. So the major cation is sodium, because it is about 140 milliequivalent in 1 liter plasma. And what is the concentration of chloride? About 110 MEq per liter. What is the concentration of bicarbonate? 24 MEq per liter. And what are the concentration of these sulfate, phosphates and other anions? These are minuscule. So we take sodium as the major cation of the body, and chloride and bicarbonate as major anions in our body. So let's see the equation of anion gap. So sodium plus potassium, and let's call these all cations letter Y. Denote all these cations with letter Y. And let's denote all the measurable anions like albumin, phosphate and other anions with letter Y. And there are also some anions that you cannot measure, like sulfate, other proteins. So let's denote this with unmeasurable anions. Unmeasurable anions. And this is measurable anions. So sodium plus potassium plus this is cations. And here chloride plus bicarbonate plus these measurable anions plus unmeasurable anions. Let's denote U with UA, unmeasurable anions. So this Y and Y cancels. So what is the normal anion? What is the normal unmeasured anions? Unmeasured anions is equal to sodium plus potassium minus chloride plus bicarbonate. But since potassium is also about only 4 MEq per liter, so we also remove potassium from our equation. So we remove potassium. So what happens that it becomes like sodium minus chloride plus bicarbonate. This is the amount of unmeasured anions. So we have not measured sulfate and other variety of proteins. So normally it is about 8 to 12 MEq per liter. So this is the normal. If you measure the anion gap in my blood, it will be about 10 MEq per liter. So because there are variety of protein molecules, sulfate molecules that we cannot measure with our lab equipment. So this is the normal anion gap or normal unmeasured anions. But let's suppose in disease states, so these extra anions are added in the blood. So what happens that this anion gap increases if extra anions are added. So normally it's 8 to 12, but if it is greater than 12, we call high anion gap metabolic acidosis. High anion gap metabolic acidosis. I can remember one of my patients, she was diabetic and she also has nephrotic syndrome. She was excreting about 6 gram protein in her urine per day. 6 gram protein. So heavy proteinuria she had, and her serum albumin was 2 mg per deciliter. No, 2 gram per deciliter. So serum albumin was 2 gram per deciliter. And she had anion gap. I calculated her anion gap with this formula, sodium minus chloride plus bicarbonate, and it came like 8. But her albumin was only 2. So I had to adjust this anion gap for albumin. Why? Because I have assumed that she had normal serum albumin concentration. No, but she has low albumin concentration. She has half albumin concentration that I have assumed. I have assumed that she might have 4 gram per deciliter, but she has only 2 gram per deciliter. So that's why we have to adjust this anion gap. So to adjust that, what we do, we add this anion gap plus 2.5 into 4 minus 2, because this is the her serum albumin and I have assumed 4. So it will be like 2.5 into 2 is equal to 8 plus 5. So it will come 13. So it is high anion gap metabolic acidosis. But when I measured without taking into account her albumin, it came about 8. So did you understand the concept that why I added extra for her? So let's understand this concept of albumin with this equation. So anion gap is equal to sodium minus chloride plus bicarbonate, but less time, this time let's add albumin. Since I have assumed that her albumin is 4, so if it is 4, then what happens? Compared to 2, what happens? This side is more. So automatically this comes low, anion gaps comes low. But if we decrease the value of this, like it is only 2, so this part will become low. So automatically anion gap will increase. That's why anion gap is more compared to what we calculate if we don't take into account the serum albumin concentration. So you understood the concept of serum anion gap. And there is also urine anion gap. In previous days they did not have the facility of measuring urinary ammonium ion, so they used urinary anion gap to estimate how much urinary ammonium ion is in the urine. Why do you need to understand about urinary anion gap? Because we have to differentiate normal anion gap metabolic acidosis, like normal NAGMA can be caused by either RTA or can be diarrhea. So if you are confused whether it is due to diarrhea or renal tubular acidosis, so you can take help with the urinary anion gap. So let's talk about renal tubular acidosis, and in the midway I'll talk about that urinary anion gap concept. So let's suppose this is the proximal convoluted tubule, and this is the distal convoluted tubule, and this is the collecting duct. So in the distal convoluted tubule, what happens that H plus ion is secreted and that is thrown out of the tubules. That is the job of the distal tubule, to secrete the H plus ions. to throw out of the kidney. And what is the job of the proximal convoluted tubule? It reabsorbs bicarbonate, it reabsorbs phosphate, it reabsorbs glucose, amino acids, water. So this reclaims whatever is filtered. So 80% of the molecules are reabsorbed here, and here what happens that H plus ions is secreted. So this is not the only function of these tubules. There are variety of other anion channels that I want to talk, but to understand this concept of anion gap and RTA, I am just focusing only few channels. So here H plus ions is secreted. No, so let's suppose this distal convoluted tubule is defective, either due to any disease or any drugs that is hampering this distal convoluted tubule. So what happens that this H plus ions won't be able to secrete. So this H plus ions will be retained in the blood. So this increased H plus ions causes metabolic acidosis in the blood, metabolic acidosis. So metabolic in response to increased H plus ions, what happens that chloride concentration rises in the blood, because if there is either low bicarbonate, it means that there is acidosis, or increased H plus ions, chloride rises. So it is called hyperchloremic metabolic acidosis or normal anion gap metabolic acidosis, because to compensate bicarbonate, chloride rises, and that maintains the anion gap. So it is called hyperchloremic or normal anion gap metabolic acidosis. So what happens that this H plus ion won't be able to excrete in the urine. So if you measure in the urine, H plus ions will be low, because this is not able to secrete the H plus ions. It means that urinary ammonium ion is low. Urinary ammonium ion is low because H plus ions is not excreted as a charged particle. It combines with ammonia to form ammonium, and that is excreted. So if we measure urinary ammonium ions, so in distal RTA, what happens that urinary ammonium ion is low because H plus ion is not able to secrete in the urine. But we cannot measure urinary ammonium ion, and this report is not readily available. So in previous days they thought that can we estimate urinary ammonium ion with just only sodium, potassium and chloride in the urine, because we can get the report of sodium, potassium, chloride instantly. So they thought that urinary ammonium ion is also is not excreted singly. This is ammonia ion, so so positive ion combines with the chloride ion. Ammonium, it is excreted as ammonium chloride. So if you can measure urinary chloride concentration, that much urinary ammonium ion is excreted in the urine. They assumed like that. So they came with the formula of urine sodium plus urine potassium minus urine chloride. So they called it urinary anion gap. So if there is low urinary ammonium ion, it means that urinary chloride is low, because the concentration of this charged particle and this charged particle is same. So if it is low, then obviously this side will be positive. So in distal RTA, what happens that this becomes positive, urinary ammonium ion is positive. But let's suppose a patient has a diarrhea. So bicarbonate is thrown out in the stool. So the patient has metabolic acidosis. So in response to metabolic acidosis, what happens that his tubules are intact. So tubules will reclaim this bicarbonate because there is already acidosis. So tubules will think that our blood has already so much acid, so I should reclaim the bicarbonate. So bicarbonate will be reabsorbed, and since these distal tubules are also intact, it will throw out the H plus ions. So more H plus ions will be thrown out in the urine. So urinary ammonium ion will be high in the urine. So high urinary ammonium ion means chloride ion is also high, because this ammonium ion concentration is equal to urinary chloride concentration, because both are excreted together. So high urinary ammonium ion means high urinary chloride ion. So this if this side becomes increased, so what happens to urinary gap? Urinary anion gap becomes negative. So in diarrhea, what happens? Diarrhea, urinary anion gap is negative. So they did not measure urinary chloride, urinary ammonium ion, sorry, but they estimated the how much urinary ammonium ion, how much H plus ion is created in the urine with just only sodium, potassium and chloride. From there the concept of this urinary anion gap came, and we still use this equation in our practice till date. But let's suppose if there is proximal RTA, let's suppose this tubules is defective. Proximal RTA either due to drugs, you have given some antibiotics that have damaged these proximal tubules, or there is any congenital defect like Fanconi syndrome where these tubules are defective. So what happens that these tubules are not able to reclaim the bicarbonate. So bicarbonate will be thrown out in the kidney, thrown out in the urine. So bicarbonate will be thrown out in the urine, but distal tubules are intact. So since bicarbonate is being thrown out, so distal tubules will sense that, oh, so lots of bicarbonate are being thrown out, so my body, my blood has a lot of acidosis because bicarbonate is going out. So what should I do? So I should throw out acids, because already there is so much acid in my body. I am suffering from metabolic acidosis, so I will throw out H plus ions. So the distal tubules will throw out H plus ions. So H plus ions will also be thrown out. So in urine you will get H plus ions. So this H plus ions, I told you that it is not excreted singly, this is excreted along with the ammonia. So there is increased urinary ammonium ion. So increased ammonium ion means you increase urinary chloride ion. So increased chloride ion means this side is increased, so this becomes negative. So in proximal RTA, the picture of urinary anion gap will be like diarrhea. So many people remember that in RTA the urinary anion gap is positive and in diarrhea it is negative, but here you see in proximal RTA also urinary anion gap can be negative. So it is not always positive in renal tubular acidosis. So basically you have to understand what is going inside the tubule, and from there you can understand this concept. So this is about proximal renal tubular acidosis and here distal renal tubular acidosis. So let me tell you one extra thing as well. Since bicarbonate are being thrown out in the urine, so here it will sense that, oh, there is lots of bicarbonate being thrown out. So to maintain the electrolyte neutrality, potassium is also thrown out from this part. So potassium is also excreted. So in urine, if you also check potassium will be high, and even the serum potassium patient will have hypokalemia, because along with bicarbonate urine, potassium will also be thrown out. And since in proximal tubules citrates is also absorbed, citrate is also absorbed. So if it defect in the proximal tubule, citrate would also thrown out. Citrate would also be thrown out, and due to metabolic acidosis, calcium cannot be reabsorbed, because in either proximal RTA or distal RTA, if there is acidosis in the serum, then there is defective reabsorption of the calcium. So calcium along with citrate will be thrown out in the urine. But since this is combines with citrate, this can easily be thrown out in the urine. But in distal RTA, what happens that due to metabolic acidosis, this calcium cannot be reabsorbed. But you know, this tubules is intact, so it is able to reabsorb citrate. So calcium will be alone in the tubules. So alone calcium will precipitate in the tubules, and this causes nephrocalcinosis. And if it is heavy amount of calcium, that causes calcium nephrolithiasis. So in distal RTA there can be nephrolithiasis of calcium, but in proximal RTA there won't be nephrolithiasis. So you understood the concept. But in both hypokalemia is there, and about type 4 renal tubular acidosis where there is hyperkalemia, I'll discuss in next part. So I just demonstrated this to understand the concept of